Okay. You will see that, okay?
Yeah.
Amazing. Okay, so this is your maternal history. This lady is a gravida 6, para 3, 2 previous SVDs. Sorry, I should say 3. 3 previous SVDs in 2002, 2006, and 2008. All were uncomplicated, but none of them were in the UK. She's also had 2 previous miscarriages at less than 10 weeks gestation, BMI of 28, and a hemoglobin C carrier. Other than that, her medical history was nothing, nothing major. In terms of her antenatal history, she had 1 episode of abdominal pain at 27 weeks. At 28 weeks, her latest ultrasound showed polyhydramnios. I think it was 10.5 centimeters, so just over that mild line. GTT was normal at 28 weeks, and her BM monitoring that she got sent home with because of the poly was also normal as well. So no concerns with that whatsoever, and that wasn't the cause for the polyhydramnios. At 40+6, she had her first episode of reduced fetal movements, so induction of labour was offered and accepted by this woman. The decision was made for her to have a PROPES as a form of induction, and this is your initial CTG. So this is your prior to PROPES CTG here. Did I mention how? Yeah, 40+6 she was. Happy with this as a normal trace? Is the baseline appropriate for gestation?
Yeah.
Yeah, baby fit for labour?
Yeah.
Yeah.
Amazing. Okay. This is your sort of 30 to 40 minutes prior to insertion. At 19:25, she was examined, found to be 1 centimetre dilated, and PROPES was put in situ. So note the presence of cycling as well. This baby's telling us that they're very well at this moment in time. Okay. So on the this is the 27th now. This is her overnight CTG was completely normal. And this was her 1 in the morning. This is around 11 o'clock. Are we still happy with this?
Has baseline
Yeah.
risen? I thought it was about 1:30 last month. All right, yeah, ignore me.
About 1:30, 1:40. What's bizarre about this one, I think, is the fact that the baseline seems to settle in quiescence at around 1:40, and yet when active is actually less so, which I just found quite interesting, because normally you'd see it the other way around, that when the baby's sort of cycling and asleep, you'd see it at the lower end of the scale, as opposed to when it's active being higher. But this baby is slightly different. But yeah, we're still happy, yeah? Okay, moving on.
Yeah.
So, sorry, did someone want to say something?
No, I was just saying, yeah, sorry, delayed reaction.
No, that's okay. Cool. So it gets a bit later on in the day. At 16:50, she's examined because she's in some distress, and she's found to be 4 centimeters dilated. So she's transferred over to labour ward, and this is our initial CTG. So what on earth has happened in the space of 6 hours? Anybody want to comment?
Is that not mum that you're monitoring?
Which bit?
I mean the bit to the right of it where you can. Is that not the? Is the green not the maternal pulse that's going up, and it looks like it's the same with the fetal?
Yeah, it is exactly that. And where it's red is kind of showing you where the crossover is. So it's showing you how similar maternal pulse is to the fetal heart rate. Or is it? So obviously the fact that this baby has now got a baseline of around 170 and mum's now tachycardic at 140, they didn't do a temperature, I don't think, at this point in time. But because of maternal pulse being so high, the decision was made for a septic screen. And then terbutaline given at 17:25. Does anybody know why that might have happened? Why terbutaline might have been our first port of call there?
I think personally, I think over the 6 hours, she hyperstimulated, and there was a kind of, the only explanation is evolving hypoxia during the last 6 hours, which we didn't monitor. But that's then calming down the contraction has a meaning here, because she progressed also from 1 to 4.
Mm. Yeah, absolutely. And also, you know, we're going by our protocol at the moment, aren't we? You know, 6 hourly or 4 to 6 hourly CTGs. This lady, we were kind of, I think, expecting to give a ProPES to and hopefully progress in labour. We knew that she would probably progress quite quickly, considering she's a para 3. But the fact that she's sort of gone quite quick may have had an impact on the CTG. However, Mr. Naguib, I'm just wondering if you can comment on this, because in terms of the terbutaline, is that realistically going to fix our baseline situation?
It is not going to fix the baseline situation. It will fix more or less your hypercontractility, and even if it is not hypercontractility, the hyperstimulation that has caused. Sometimes I am in labor ward and sometimes people tell me, oh, but she's contracting only 3 to 4 in 10. But if the 3 to 4 in 10 for this baby is too much, it will still be hyperstimulation for this baby. So it will definitely like give a breather to the baby. Even if it doesn't ameliorate it completely, it will make my baby have a better time. Yeah.
Okay, perfect. So 17:25 terbutaline was given and the septic screen was fully taken. From my understanding, this lady's got a normal BMI of, I think, what did I say, 28, but the monitoring on this woman was incredibly difficult. I think she was in quite a significant amount of distress, from what I can sort of understand from the documentation, but she was very, very difficult to monitor throughout this entire labour, and you'll see that as the CTG continues. So we'll continue it on now. At 17:26, the registrar's present, examines this woman, finds her to be 5 centimeters dilated, and ARMs her. I think the meaning for the ARM in this case was purely to place the FSC, because of the difficulty that we were having with the monitoring and the continuous confusion between fetal and maternal pulse. And there was parts of the CTG it doesn't really pick up, and I can't sort of determine exactly where, but there was parts of the CTG where we were using abdominal monitoring as well as the FSC to try and see where this fetal heart rate was actually sat at as a baseline. There was a delay during the septic screen because this woman was very difficult to cannulate. I think there was 3 attempts in total, and then the anaesthetist was then called to pop the cannula in, just due to difficult veins. But eventually we started on our sort of protocol. Hartmann's was started, IV paracetamol was started, IV cefuroxime and metronidazole was started as well, and an indwelling catheter was put in, just because the difficulty with the cannulation, she had reported not being drinking, staying not very well hydrated throughout the day as well. Obviously contributes this massively. So hopefully the Hartmann's will sort it out, but that catheter will enable us to be able to get a good sort of fluid output and input monitor on this woman. But pulse still remains as high. I've put all of the obs that I've got that were recorded on the tracings as well. So in this sort of 30 minutes, there wasn't any observations done. But I think there's some on the next slide. Anybody want to share their thoughts?
Why are we not sectioning her?
I think because of the sort of mum's instability at this point with a pulse rate that was high, they wanted to try and stabilize her basically before doing anything or making any drastic moves. And I think the hopes in this situation was that the IV antibiotics and the paracetamol and whatnot would help make mum more stable to be able to transfer to theatre.
So it was on the plan. We weren't going to continue with labour.
No, it wasn't. It wasn't on the plan to
I-
sort of continue, but because she was a para 3 as well, the element of okay, 5 centimeters ARM, let's give her the medications necessary to try and resolve and help the situation. But theatre was definitely in the back of the mind.
I think with the ARM as well, it's being aware that you're going to cause problems. Like that's going to speed up the labour and that's going to cause more distress on the fetus as well. So it might be good for the FSC, but actually, is it long term going to affect this fetus more with the ARM? So just being aware of that as well.
I mean, in the bigger scheme of events, I would be agreeing with the management so far. You know, I wouldn't, you know, like immediately section her. Having progressed from 1 to 4, giving terbutaline is right, then ARMing is right, then FSE, and I am by the bedside trying to see. Sectioning is in a BMI of 28 is not difficult. It can in 5 minutes baby will be out. So in the bigger scheme of events, I think the management so far is going. Yes, the CTG is not perfect. I agree, but at the same time, we are just doing things. We are trying to remedy the situation. We give terbutaline, we ARM, we put an FSE. We are just trying to make the situation clearer. So if I was there so far, I don't know the case. So if I was there, I would do the same and stay in the room.
Yeah, absolutely.
But can I ask, would you like get an epidural thing ready just in case it gets worse so you are prepared to do a section then?
Again, from the anesthetic point of view, which we have discussed many times with them, for them, a quick spinal is better than an epidural. And an epidural that is going to calm her down, that's absolutely fine, but not from the point of view management. If you are thinking you might section her in another 10 minutes, 15 minutes, 20 minutes, I would be more inclined to be observing what's happening, and then the anesthetist is putting one single shot spinal rather than inserting the tube of the epidural. So they don't prefer that. And sectioning under epidural is not usually, sometimes it's fine, but sometimes also I find it so difficult because the lady is coughing and the bowels is coming out of the abdomen and the muscles are not relaxing. So section wise, it is quite not as nice as spinal.
Okay, thank you.
Thank you, Mr. Naguib. Okay, so baselines remain sort of 160 for a little while now. At 18:05, FSC was reattached. The lady was now requesting an epidural, but unable to do so due to query maternal sepsis. Blood pressure is 135 over 85. Pulse was 146. And oxygen saturations were 94 at this point as well. I don't have a respirate or a temperature at this point either, because these weren't recorded anywhere. But the CTG just continues.
So when the FSE was reattached, what was she?
The same.
Right. So
Yeah.
at this point of time, now that I have done the ARM, I have done everything, and the variability is nearly, I don't know, I can't see any variability here. I feel like it is 2. I would be more worried with those kind of chemoreceptor deceleration. Here, I have done my terbutaline, I have done my ARM, I have done my FSE. I am more inclined now to say, you know, I will section now. This is when we can now have done everything and go for the section.
I'd also have, yeah, I think I at this point would be saying, okay, let's get pre-meds ready in the room. I think the thing that worries me as well is the fact that although we can definitely determine the difference between fetal and maternal heart rate here, there are still an awful lot of periods of time where they look like they're exactly the same, and the machines are telling us that they're the same as well. Whether or not they are, it's very difficult to tell, but they kind of mirror each other a little bit, the maternal pulse and the fetal baseline. The only sort of good thing I would say that's reassuring us that these are two different things is that you can notice that the maternal heart rate is increasing alongside the contractions whilst the fetal heart rate is decelerating, which is a good sort of indication that we have definitely got two different people essentially. But yeah, variability is now starting to reduce. So if we are sort of septic, we're now trying to fix that. We're trying to bring mum's temperature down. We're trying to make sure that she's more stable. However, her pulse is still 146. And this is, I think, about half an hour after we've started fluids and IV paracetamol and whatnot, but it doesn't appear to be helping. Also, I know that, you know, we sort of sit on SATs quite a lot. Oh yeah, you know, 95% and over and whatnot, but we are bordering on low. So this mum is clearly deteriorating, and in this case, so is the fetus alongside her.
There is two hands up, Sorsha and Amber.
Go for it, whoever.
Go first. You had your hand up longer.
Sorry, I was just saying, what colour was the liquid? Did I miss something? Because you said
Clear.
AOM? Clear,
Yeah,
it was
clear.
clear. Okay. And have we did we do a temperature? Have we got any blood results back?
No blood results back yet, and the temperatures, all of the ones that were taken, I've put on here, so there weren't any at this point.
Just a quick question. So
Yeah.
the plan of care now, so we're at the end of this CTG, we're at 6:30. You've obviously given time for the septic screen to be taken. You've given all the medication. You've given it half an hour. She's requesting epidural because she's back contracting 2 to 3 in 10 roughly. She's still unstable with her heart rate, raised at 140 odd. You think about, obviously you asked that question at the start, is this baby fit for labour? At this point, if I was doing my fresh eyes at 18:27, would I be asking myself, is this baby fit for labour? And if my baby's showing me signs of, as Naguib mentioned, chemoreceptor decelerations, I've got to think of that risk plus potentially infection. So hypoxia plus infection is not always a good call. So what is the plan right now? What did the documentation say? Where are we going?
The documentation at the moment is basically wait for the medications to have effect, and if that doesn't help, then to go to theatre. But there's no clear plan like, oh, we're going to go at this point and we're going to wait for this however much time. It is just a sort of sit and wait approach at this point and hope that it gets better.
So are we still using Figo? Would you say that you're going to do fresh eyes every half an hour? What would in the interim, what are we doing?
Well, you'd have in the interim sort of period of time, like Mr. Naguib said, you know, as soon as he's given all those medications, he'd want to be in the room. And I think the registrar needs to be present for sort of continual review at this point. You know, midwives coming in and doing fresh eyes, we're clearly going to mark this as sort of suspicious, bordering on pathological as per Figo. At the moment, we are moving to that physiological approach in this year. I need to just write the guideline basically. But yeah, it's a case of, I think there was definite concerns that were raised by a lot of the midwives that were on this shift, and there was a lot of, okay, we need to go to theatre. However, that at this point it was just a case of, okay, let's just sit and wait for a bit longer and see if things do improve.
Okay. What hypoxia would we say this was then? if I was doing my fresh eyes at past, what would you say it is?
I'd go with gradually evolving personally.
Thank you.
Because we've gone from well, we didn't see any baroreceptors. There's a possibility that they could have been occurring while she was on our antenatal ward, but rising baseline, chemoreceptor decelerations, and now we're losing the variability. I would say we're currently on that step ladder to a terminally ill baby. So this continues. VE is performed because the PROPES is still in situ. Wasn't removed at the previous VEs. Still no temperature that's checked in this point, but the baseline does look like it's returning back down to sort of what it was before. Maternal pulse remains at 134, 133.
So, sorry to interrupt. Can I just say, did they forget that the PROPES was in there because they've given terbutaline?
Yeah.
Oh, so it was just an error that they forgot the PROPES was in there.
Yeah.
Okay. Yeah.
Is that human factors because of the deterioration of the CTG potentially?
Yeah.
And the move from antenatal. So that might be really interesting to look into.
Yeah.
How to
There
work
was
that.
it was a very quick escalation from Hope Ward to our Labour ward in order to transfer the woman over. I think that it was a human factor error, like this just got missed. But obviously, hindsight is a wonderful thing. We can look on this and we can learn from this case that actually, if you are looking after somebody on our antenatal ward and you have concerns with the CTG, or if you find someone to be in active labour, that PROPES removal is absolutely necessary as one of our conservative measures, specifically if we've got concerns with the CTG as well. That would have been one of the first things to have been removed had it been remembered at the time. Okay, so we'll move on. Respiration's now 26. Blood pressure's raised up to 145/89 and pulse is 128. I still don't have a temperature, but the second bag of Hartmann's has now been started at 1923. So bear in mind as well, this is our sort of handover time. We get handover at 8 o'clock. So more human factors are going into being taken into account here. You know, you've worked for 12 hours now. We're all probably thinking at this point, okay, well, hopefully, you know, it doesn't look too bad. It looks like it's returned to baseline. So let's wait until the night staff take over and then they can take it from there.
What's the urine output? Why did they start a second bag of Hartmann's?
Second bag of Hartmann's because they put the first one through stat. And they wanted to keep it going. Urine output, I think, was reported as normal at this point.
So is this why the baseline? I think it was Dagmar who mentioned at the last meet, wasn't she? Was talking about when you put fluids up and dropping the baseline, mum's core temperature.
Mm-hmm. Yeah. So in terms of the sort of research behind that, there isn't an awful lot, although it does make complete sense.
Yeah. I went
the
looking,
fact that
I couldn't find any, but it makes
no, I
sense.
couldn't.
It absolutely makes sense, but I couldn't
Yeah.
find the evidence.
So just to sort of share that with those that weren't here for our last session, one of the obstetric doctors that was present on the case review mentioned that obviously you're putting fluids at room temperature, which is roughly 24 degrees, into a woman through her vein, whose core temperature is sort of sits between an average of 36.5 and 37.5. That cold fluid can sort of sometimes be seen. This is something I've seen in practice, but like I said, there's no sort of evidence to back it up per se.
Cara,
yeah.
I've got an actual response in an email because I went looking for you. I went like you looking for the evidence, and then I emailed. Replied to me in an email. Do you want me to read it out?
Yes, please. So
it says, indeed, fluids given by us are usually room temperature, i.e. 22 degrees. It therefore reduces mother's temperature, usually 36.5 to 37.5. The mother is the person via whom the baby's heat exchange works via the umbilical cord and overall amniotic fluid. As such, the base rate rise can be blunted. And then she's just gone to beware theories that baseline rise is due to fever, but it might just be inflammatory markers, cytokines, and then it's questionable if it influences the baseline rate. It should still be the case if the temperature affects the parasympathetic nervous system effectively. That's why it would have been interesting to have known what was her temperature, this woman's temperature.
Yeah, absolutely.
And then she just goes on to say, so in theory, yeah, nothing much, just that really.
Yeah.
So yeah, and then I went looking. So I just wanted to, because I actually thought I'd wanted to be like, you really thoroughly understood it. So it was just nice that she replied back. But yeah, just like what you said there, I thought there might have been a bit more in it, but there isn't.
Yeah, it's a difficult one because it does, like we said, it does make total sense. However, we you know, if we can't back it up with evidence, then we can't necessarily use that within our practice and whatnot. But it's just it's definitely something to consider, specifically in these cases. So I think, are we all still in agreement that we'd like to go to theatre, or are we happier now?
No, I want to go to theatre.
Anyone else?
Yeah, we still want to go to theatre. Yeah.
Cool. I definitely agree with you. Okay, so we've now got a blood pressure of 136/82. Pulse has come down to 126 from up to about 150 at one point. SATs are still 94%. At 19:44, she's feeling pressure and is found to be 7 centimeters dilated on VE. And this is sorry, I'm going to have to go back. 18:35, she's 5 centimeters. So about an hour later, she's progressed 2 centimeters. So now that we know that, does anybody want to change their opinion? Does anyone want to think, okay, well, she's progressing now, so actually if we sit and wait, she could be fully and push a baby out quite quickly? Or are we still all of the opinion, let's go to theatre?
It depends on this 7 centimeter is where is the head. So if the
High.
head is like high,
Yeah.
if it is high, I would still go to theatre. If
Yeah.
it is low, in many occasions, 7, while I'm examining, she becomes 9, then and fully, then baby out. So I mean, yeah.
Yeah. Absolutely.
I think it's being aware as well. If you're pushing on a heart rate of 140 at the back end of this CTG as well, her heart rate's sitting at 140. Just think of that impact if she starts actively pushing on that, and how that may affect the maternal physiology as well. So it's not just the fetus. Obviously, we're looking at the CTG, but actually, how might that mum be sort of clinically as well? We're getting a bit caught up sometimes with the CTG, but actually, she's clinically still quite unwell. So being aware of that as well.
Absolutely. Would anybody want to give oxygen, considering her respiratory rate is 26 within the last half an hour and SATs of 94%?
I just want to know why her pulse is 140 after giving all of that as well. So
No.
the whole clinical picture. Why is she so poorly as well?
Yeah.
Her
No.
SATs are dropping essentially.
I think oxygen here has no role, to be honest. 94% is quite good. And we need to understand that the respiratory rate is high because of the sepsis, not because of the decreased lung capacity.
Yeah, I didn't know the answer. I genuinely was asking. I just it's not something that we often come across regularly, because we don't often have that many women that are quite unwell, you know.
Yeah, you can give oxygen when you have more of a restrictive lung disease, when you have other things, but not in this situation, really. Dagmar has put her hand up.
Sorry, I joined late, so therefore I do not know the context of the story. But regarding oxygen, so it doesn't help with hypoxia in the baby, but the mother. So if essentially respiratory rate is above 24 and SATs are below 94, and that's essentially RCOG guidance, then you should be putting her on oxygen, because it's about her own oxygenation. And her increased oxygen demands, if she essentially is struggling, doesn't help the placenta either. But there's no evidence that putting mom on oxygen helps the baby. So, and you mentioned something about evidence base regarding fluid. So there are lots of things that we do that aren't evidence-based, and where we will probably never find any evidence, because you always have to kind of think the clinical trials that you have to kind of set up with 80% power plus, kind of error rates 0.5 to get a statistical margin. They are huge. And dependent on what you're testing for, it quite literally doesn't exist. So therefore, when you asked me, I think via email about the effect of it, so I could only find 2 pictures that I've taken pretty much on the shop floor, and I'm just therefore encouraging you do that too, and essentially kind of collect, because I stopped taking pictures. But it's if you lower down the maternal core temperature, you quite literally, with stopping the fluids, see an increase pretty much within 10-20 minutes. And I think I attached one of the kind of images to the kind of email, and it's quite you only need to do that a couple of times, and when you see that, there is not much more convincing required. So it's essentially about reducing maternal core temperature. But yeah, it's like the rule of 3 for acute hypoxia has no clinical trial that is underlying it, but it's based upon what we know regarding hypoxia, and it's based upon how long do you have if you have a uterine rupture to get the baby out before it's dead. And there you have plenty of data, and you will never get a clinical trial to support this. So I just wanted to kind of say, the majority of guidelines that you're at the moment following, including NICE, intrapartum, doesn't have evidence to it at all. So the question is, what is essentially more sensical? Yeah, so it's a lot about thinking.
No, I absolutely agree with you, Dagmar. I've seen it with the fluids myself, but then when I'm trying to explain this to the consultants at the hospital, I was going, well, show me the evidence. So I've spent like weeks looking, trying to find something, but
doesn't
no, you're absolutely right. I've seen
take pictures and essentially kind of disseminate that. If you kind of come up with a clever idea to kind of do that as a trial, then maybe across a couple of units we can do that. But it'd be because we can all see it. Yeah.
Yeah.
Absolutely, and also self-auditing and noting what things you do in your own practice. Mr. Naguib always says that he self-audits himself on a continual basis. So if we start sort of noticing these sorts of things in our own practice and then taking them further and teaching others about our own experiences, that's kind of, and seeing if other people have the same experiences, then we're all going to learn from each other, aren't we, without having to use a clinical trial as evidence. Perfect. Dagmar, this is a para 3 previous SVDs. Last one was in 2008. Nil medical history, polyhydramnios, but otherwise pretty routine pregnancy. Currently.
Do we have a focus? So how high was her temperature, if I may ask, at the beginning, and what was the
there wasn't one taken, I don't think.
Right, and do we have lactate back for kind of systemic infection, because that kind of also increases baby's risk for hypoxic injuries? And the other question that I have is COVID.
COVID swab is negative, and the lactate, we haven't got any blood results back yet.
BBGs are processed within less than 20 minutes, pretty much on our NICUs. So no.
Yeah, that one wasn't done.
Okay, all right. Okay, thanks.
Okay, we'll move on to the next slide. So now we're getting even increasingly worse contact on the CTG again. This is still remaining with an FSC attached. I don't know if anyone's actually in favour of the ones that we're currently using. They do work, but the contact on them is just really, really quite awful. This is something that we definitely don't need research to determine, because I think everyone has the exact same struggle every time they they go on, they try and put one on the baby's head, because they can be completely and utterly attached and yet have awful contact. But as you can sort of see, the baseline is back remaining where it was previously, at the very beginning of her labour, but very difficult to sort of decipher, because obviously we can't fully determine whether or not this baby is well, because we've not got the contact that's good enough. There was multiple attempts to reattach this FSC. I think they must have done it about 4 times, I think. Because even this was the best we got, even better than an abdominal transducer.
Ara, just a quick question. Did they do
Yeah.
a bedside ultrasound to have a look at the fetus to see where the location of the heart was if we were struggling, but also to see any fetal movements at the bedside?
Yeah, they did.
Okay.
Yeah, sorry, I didn't put that in there, but they definitely did an ultrasound. I think after the first fail of FSC, and the baby was in normal position.
Movements.
But I don't know why we had such an issue with the contact. I'm really not sure. Anyway, I'll move on to the next slide. So blood pressure is 130/88. Pulse has now gone up again to 140. Resps of 18. Sats of 95% and temperature of 36.9. I just want to highlight here, I'm not being accusatory or anything at all. However, we had one person that did a set of observations and found her respiratory rate to be 26 alongside a raised blood pressure and a raised pulse and lower sats. And now within an hour and a half, the respiration rate's gone from 26 to 18 when none of the other observations have changed. I just want to highlight the importance of an accurate respiratory rate measurement when we're doing our maternal observations, because I don't know, I'm not trying to be accusatory here, but I do think that that's a little bit odd. I don't know if anybody else agrees, but yeah, we're now on the night team as well, so the night shift have taken over, and this is what they've come into. So hopefully they've gone back and reviewed the previous CTG just to see what changes that have been made and whatnot. But yeah, and the registrar plans to come and visit this woman first, I believe, as part of the ward round. Anybody want to comment on the CTG at all?
Bit better.
I am feeling that still I have no variability. I don't know whether it is because it is on my phone, but I can't see any variability for the last 2 hours or something. So I still feel that she and with a pulse of 140.
Yeah.
This lady is struggling. The baby is struggling, and the last delivery is 2008. It's not that 2 years ago. So we are really going on with a relatively prime kind of. I believe that I wanted to section an hour ago or more.
Yeah, Miss Sinigib, it's not your phone. In the decelerations that you can see here as well, I mean, we are very much pencil tip variability as well. So there might be periods of time where it is more than 5, but I would argue that the majority of the time it's actually very much less. So I'm definitely in agreement with you there. Does anybody else have any other comments at all?
I think people have just been, maybe have they been falsely reassured because they think this baseline has settled from what it previously was?
That's
They're just
what
sort of fixating on that baseline.
Yeah,
like
I think
just
you're right.
And the shouldering. I was going to mention the shouldering.
That
yeah. Yeah, we look like we're transferring back to sort of baroreceptors with these shoulders, but the fact that there's absolutely no variability within them is our very non-reassuring sign here. So yeah, I think you're right, Amber. I think, night staff have taken over, had a look at the CTG, noticed that the baseline has returned back to what it was at the start of the labour trace and antenatally. So yeah, maybe that has provided us some sort of false reassurance. We'll move on to the next segment. So at 20:58, the doctors do a ward round, and the VE declares the cervix 4 centimeters dilated, and actually it deflexed OP. And at 21:10, the decision was made for a cesarean section, followed by a nice second dose of terbutaline at 21:14.
Who did the VE?
The registrar.
Who did the previous ones?
One was a registrar, one was the midwife in charge, and I think one of them was their midwife, case midwife.
I don't think there's blame in regards to the VEs, but I do think it's that whole clinical picture again of everyone's rushing to do something, that human factors. We're worried she's got sepsis. We want to quickly ARM her. We want to do all these different things, and I think that might have impacted. And she hasn't been contracting probably as she would like, so I wouldn't blame the VEs. But it's interesting.
But also, I think the fact that there's been 3 different VEs by 3 different people also is going to contribute to that, because, you know, my 4 might be your 5 might be my 4. There's always that element of difference between clinician, and the fact that the examinations weren't done by the same clinician each time is obviously difficult, because the cervix may not have progressed at all, but what one person might have said is different to the other, which is why we also encourage our continuity of care when we're caring for women in labour. Obviously, it's different when it's a decision-making VE and our registrars come and do the examinations and whatnot. But yeah.
I like to comment on, I am very happy that Sorsha is saying that she doesn't want to blame the VEs. But unfortunately, the VEs are essential. And I know my 4 might be your 5, but my 4 cannot be your 7.
No.
And I must admit, now and again and again and again, and reviewing the cases coming and coming and coming, and will continue to come. I'm not saying anything, because we accept that we are not all like clinically sound like each other. Cases coming from 2 to 4 to 6 to 8 to fully, then somebody comes and says it's 5. Similarly, VE after VE after VE, and then we put an FSE, and then we deliver the baby breech. I'm not again here blaming people. I know that it will continue to happen. It happened in many of the hospitals I worked in, and it will continue to happen. But I'm hopeful that whoever is saying 7 and 9 and finds out that it is 4 doesn't put the head in the sand and say the others are idiots, or I am right and the others are wrong, because we need to learn. And when I do something wrong and I feel like my examination said, for example, before a hysterectomy, it is a 20-week size uterus, and I go in and find it is a 32, 36 weeks, or on the other hand, it is 8-week size uterus, and I should have done a laparoscopic hysterectomy, not abdominal hysterectomy. I reassess my examination, myself. Why did I make this mistake? So everybody should be his own or her own benchmark, and trying to say, I should improve in that. Let's try to go back. It happens from people coming from birthing center. 4, 5, 8, they come to labor ward and they are 2, and so on. So we need to reevaluate ourselves, and without blame, without anything, but at the same time, don't ignore it.
Just on the end of that, Naguib, I think that's a really valid point. Just for standardising VEs as well, there's loads of new, just the education Cara as well. You can buy cervixes, and you can get staff to obviously practice this. And this is a fantastic tool. If you're noticing that actually staff are making these errors, getting the standardised approach so that everyone can participate and learn. And then actually you can see how much your staff and actually the outcomes would improve. So things like adding it onto prompts or adding it into like these meetings or doing it ad hoc at handover and things like that, is you can make it into a tool and fun, but actually can do a standardised approach at the same time to help staff. It's just extra, sorry.
If you
That's a
can,
good shout.
if you can send us social
Yeah.
this where to get these services from, and we can ask like the educational team, and they can get it.
Yeah, we'll definitely look
Yeah, we'll
into
do.
that one. Perfect. Right, we'll continue, guys, because I'm aware that we've not got very long left. Third bag of Hartmann's has now started, though, at 21:30. Blood pressure still remains raised. It's actually going up even further now with the diastolic now at 99. Pulse remains 138. Resps of 19. Sats of 95%. And temperature of 36.9. I think we're all in agreement that we're moving to theatre. The decision's been made at 21:10. From my understanding, the unit activity was completely normal at this point, so I'm not quite sure what the delay was in transfer. However, we will continue. So decision made at 21:10. At 22:07, so we're now an hour later, this happens. The emergency bell is pressed. 22:08, the cervix remains 4 centimeters dilated, and actually what could have been a Cat 2 an hour ago has now been moved to a Category 1 emergency cesarean section. And a third dose of terbutaline was given. Mr. Naguib, this was a question I wanted to ask you, and I think a lot of people would benefit from. We don't have anything in our guideline about how many times you can give terbutaline or anything like that. It's not really much in our guideline other than as a conservative measure. I just wanted to ask you about how many doses is actually safe to give, or if there's any thing additional that we can read to sort of establish the answer to that question.
So the answer to that, Cara, is how many per what? How many per hour? How many per labor? How many per So so that's why the answer might be slightly extensive, which I don't want to. So if I am, this is my views on terbutaline. I love it, but at the same time, if I am 2 centimeter and I give terbutaline, and I am now 3 centimeter and I give terbutaline again because the CTG is like evolving hypoxia or on that old classification abnormal, I wouldn't give more, I would section. If I am giving, if I have given 2, then we are 2 hours later, 3 hours later, 6 hours later, and we are moving to theater, but the CTG is not good, and I want to give 1 dose more, third one, so I can have this 20 minutes window to have a spinal, that's fine. Okay. If I have given 2, then third one, then I'm moving to theater in another 12 hours, and I'm giving the 4th one. Yes.
Yeah. Okay.
So it's not one size fits all. It is how many per hour or how many per labor, and how many you give, and the aim of giving. And the most important here is the aim of giving.
Yeah. Okay, amazing. Thank you. That definitely clears things up a bit. So we've moved 22:14.
Sorry, Dagmar has raised her hand up.
Oh, go on.
Just wanted to kind of say, from the medical point of view, so you give significantly higher doses in an acute asthma attack, either IV or subcutaneous. So normally it's IV on ITU, no? So it's possible to kind of give more. It's not that you're overdosing someone, but you have to kind of look into what a beta agonist does. So from our point of view, if you give more than 2, and that's pretty much within 2 hours, think, because there's usually something that you're overseeing. And a cut 1 does not replace you to go, or terbutaline doesn't replace you to go to theatre fast, particularly if you have an acute hypoxia with no variability. And it's contraindicated if a mother is bleeding, so abruption. It's contraindicated usually, or you should be really cautious if you have a heart rate above 120, because beta agonists increase your heart rate. Or if you have any known cardiac condition, pulmonary hypertension, or there was one third one. Oh, if you're kind of diabetic or have potassium distortions, because all of that is affected by a beta agonist. I hope that as far as I remember my medical kind of bits, yeah.
Thank you, Dagmar. That's really helpful.
Can I
Really
ask
helpful.
quickly? Sorry, what's
Go,
the
Indra.
life this terbutaline has? How long would it last in the system?
The effects of terbutaline can last for up to 4 hours after it's given, but the immediate effects within sort of 20 minutes.
Okay, so
Correct
we
me if
can.
Correct me if I'm wrong.
I don't think it lasts 4 hours, but
The long term, is it not the long term
oh,
effects? The long
till it
term
goes
effects of it.
yeah. So you mean till it goes completely from the blood, possibly?
Yeah, yeah, it's 4
So
hours, I think.
after 20 minutes, if needed be, we can possibly give another one.
You can, yes, but again, Indra, you know, what are you giving it for? I mean,
Yeah.
you have given one to calm the contraction, and it has calmed or not. If it has not calmed, giving another one in 20 minutes, because like people in ECV, for example, in many hospital, and I started it recently, give 0.5 actually, not 0.25. So you can give, yes.
Oh. So
Yeah.
is that what we do now, 0.5?
No. It's not what we do. The guidance is 0.5, but I found my success rate increased with 0.5. Then I asked neighboring hospital, and one of, again, somebody who I know does ECVs and is more successful, does 0.5. So the whole ampoule.
Oh.
Yeah. So
That's
what I
really
want to say is
interesting.
0.25, and another 0.25 is not like a dreadful dose from the medical point of view. Yeah.
Okay. Thank you.
Perfect. The decision, although the CTGs appeared to sort of recover in theatre from the previous sort of prolonged deceleration, when we got into theatre, decision was made for a general anaesthetic just due to maternal cardiovascular instability, because her pulse rate was still incredibly high and her blood pressure was still very much raised as well. So GA was done at 22:45 and delivery was within 5 minutes. Does anybody have any final questions before we guess the gases? And I know that there's more people on this call than have spoken, so everybody needs to speak up and have a guess here.
Before the gases, I just want to just say a quick comment to my colleague registrars on the call. When you do the cesarean section for such situation, which has been going on for, I don't know, 12 hours or I don't know how much, with a para 3, with a sepsis, please, even that she's 4 centimeter, treat it as a fully dilated cesarean section. When you do the incision on the uterus, do it high and take extra precaution while you are delivering the head. Protect your hand, or if you are delivering with the right hand, protect it with the left. If you are delivering with the left hand, because inadvertently in this situation with the sepsis, with the more or less the contraction that was going on for a long time, you might have bad extensions. So be vigilant to open higher on the uterus in order to have less extensions. So that's it.
Does anybody else have any further comments?
Dagmar and Amber have got their hands up.
Yeah, go for it.
I think Dagmar was before me.
Sorry, I'd forgotten to put it down.
Oh, so I was just asking because it was like just going back to what Dagmar was saying, and I'm all in agreement because this woman's had like 3 doses of Tolin, and my understanding is it's a conservative measure, it's to bide you time. So just looking at the whole cases, like we've given a lot of Tolin and then sort of really acted at the end. But was it you that said, Dagmar, that Tolin raises the maternal pulse?
Yeah,
so could we have done this to the mum?
No.
Pushed her pulse up. I mean, I totally agree. I don't like the CTG, but I'm just like looking at things and trying, because
maternal
it's all
pulse
about management, isn't it?
Yeah. Maternal pulse was raised from when she initially came over to the labour ward. The fact that we had to give Tolin on 3 separate occasions most likely did have some kind of impact. But before we'd even given anything, her pulse was raised. And despite fluids and a septic screen, it didn't come down pretty much less than 120 throughout the entire last few hours.
Well, thank you.
Cool. Who wants to guess the APGARs and the gases in this case?
Being aware that GA will affect it as well.
Yeah. Go on, Saoirse, what are your thoughts?
Okay. Gases, you're going to look at maybe arterial 7.15, basic excess -4, 5. I reckon this baby's got a high lactate as well, because I reckon it's septic as well. And then venous 7.27, 7. Yeah, 7 point normal venous, I think, with a sort of slightly raised basic excess 4 or 5 again. But yeah, I think the lactate might be high.
Okay. Anybody else want to have a go?
I'm going for a venous of 7.15, to be honest. I feel like this baby is
Venous of 7.15.
Yeah. So arterial maybe 7.0, 7.05. So between 7.0 and 7.1. So yeah, I'm low one lower than Saoirse.
Okay. Anybody else?
I would have thought it was a bit lower.
Yeah, I think it's going to be low pH. I think it's going to be a high base excess. I think the baby was buffing, and I think it's going to be a high lactate.
Okay, I'll put you out of your misery.
Go on.
So Naguib, you were very, very close actually. Very close. APGARs were 3, 3, and 4. Gases, arterial pH of 7.19, base excess of -6.1 with a lactate of 5.5. Venous pH of 7.23 with a base excess of -8.4 and a lactate of 4.6. This baby required 2 sets of ventilation breaths followed by 2 sets of inflation breaths followed by ventilation breaths. The heart rate remained above 100, but the baby was intubated during resuscitation, I think, within the first sort of 10 minutes and extubated at 3 hours of life, and was treated with broad spectrum IV antibiotics. The woman was quite unwell in theatre as well and lost 2.2 litres. So it ended up with a pack and a balloon in situ.
Did you swab the placenta? Was there any signs of your baby's cultures come back with anything?
Cultures for the neonate came back completely negative. Pardon?
Yeah, it's just like humming. Yeah.
Oh, sorry. But mum became very unwell postnatally.
Did she have anything in her cultures?
I don't know what came back in her cultures, but she was ill for like 3 days and remained on labour ward. So I think they were sepsis was the main thought process.
What would would be the learning from this? All right, sorry, Shiv's got a hand up. Sorry.
Sorry, I just wanted to ask, was there any comments about the tone of the uterus at section?
Yeah, the EBL of 2.2 was mainly due to tone.
Okay.
I guess you wouldn't. I think that's one of the risks with tebutalin as well, isn't it?
That's why I'm
Yeah.
just asking what the
Yeah.
what was the tone? Is that what we're saying it was? Like, definitely was. So I just was asking. That's all.
No, I feel it is more of a 6 hours of possible hyperstimulation rather than the last uterine. Like this is a uterus that was knackered rather than only medically speaking terbutaline. But I mean, possible contribution. And I don't know whether there is a possible contribution of some extensions as well. I don't know. Was there any surgical extensions on the uterus?
I don't think so, Naguib. Not that I could sort of decipher.
Okay.
Is there another word for it? Extensions.
Usually it is extensions. No. Yeah.
No, I don't think so then.
Did it extend into the broad ligaments? Like was any surgical something? No.
No, I don't think so. I think it was all sort of hypertonia. They gave every PPH drug that we could possibly give.
And the sepsis also causes such.
Exactly. We all know that when women are septic, that they do tend to bleed more significantly as well. So I don't think we can just say specifically, oh, it was the tebutalin that was the reason that this EBL was so high. I think it's a collaboration of like all of the different factors here.
And the hyperdynamic circulation also being
exactly
140 per minute.
Yeah, and I think she became pyrexic after delivery as well, and remained pyrexic for a period of 24 hours. So although there was very sort of limited temperatures done in labour, the ones that were done were sort of within the normal boundaries. She spiked a lot post-delivery.
Yeah. So I mean, Sorsha, you asked what is the learning from this? I think the learning from this for me is re-emphasizing on an important point that we said many times in these sessions, the clinical picture. And many times we insist on something that we are not really aware of, that, oh, she's para 3, she should do it. It doesn't have to happen. It doesn't have. And we need to treat every single labor, every single pregnancy in isolation. Yes, put together that she's multip, but see if the multip has delivered recently, like not 14 years ago. See if the sizes of the baby have changed. See if she's now diabetic. See, there is many factors. It is many things, not one. But we keep insisting on a multip should do it. It's not a must. And also, secondly, early intervention would have, number one, got us a nice baby that it doesn't need so much extensive resuscitation and less PPH. If we intervened when we said we want to intervene 2 hours, 3 hours ago, I don't think we would have ended up with 2.2, and I don't think we would have ended up with a so sick baby.
Yeah. The good news is baby's now made a full recovery, which is good. And mum and baby went home, I think, on day 3. But
excellent. Yeah. No, it is a very nice case, Cara. Thank you so much. It is lovely.
Thank you, everyone, for contributing.
I like the thumbs up that came now. Yeah, very nice.
I can't see any of them.
Thank you.
Dagmar's got a hand up.
Go for it.
Talking about evidence base, there